Good morning everybody. Today we will be discussing about the analysis of different motions in tennis. All of us know that tennis is one of the most common racket sports in the world. It's a non-contact sport played on a court of around 78 feet long with a net of 3 feet height. And the width of the court in case of singles it is around 27 feet and in case of doubles it is around 36 feet. Regarding the racket, there is no weight restriction for racket, but a heavy rackets always cause injuries. So usually in earlier days, the aluminum and metal rackets, and wooden rackets were used. Now, but it is heavy. These rackets were heavy, so there is more chance of injury even while using these type of rackets. Now, the rackets are made up of light material and it is made up of fiberglass, graphite and titanium. And regarding the grip size, the recommended grip size should corresponds to the distance between the ring finger and the palmar crease, that is the proximal palmar crease. A ruler has to be placed between the ring and long finger and find out the distance between the proximal palmar crease and the end of the edge of the ring finger, and that should be the recommended size of the grip. Now regarding the tennis ball, it's an inflated rubber which is covered with fabric, and studies are saying that the service motion, the speed of the serve is around 140 miles per hour and the return motion is around 85 miles per hour. Now we will go through the different motions available in the tennis and we will go through its biomechanical and its analysis part. The first motion we are going to discuss is the service motion or serve motion. Serve motion can be divided into 4 stages. The first one is the wind-up phase, second one is cocking phase, third one is acceleration phase, and the fourth one is the follow-through phase. Now the first one is the wind-up phase. Wind-up phase means it is the starting motion until the ball release or toss. So wind-up motion begins with the tennis player standing with the shoulder in line with intended direction of the serve and ends with the ball toss or release. The body weight will be usually on the forward foot and non-dominant arm uses for the tossing. So non-dominant arm which is used for the tossing will be non-dominant arm used to toss the ball up in the air by lowering the limb with the wrist extended, then lifting the hand forward overhead by flexing and forwarding the shoulder and extension of the elbow. So non-dominant arm will be used for tossing the ball. At the same time, the dominant shoulder will be extended, externally rotated and slightly abducted, while flexion of the elbow, submaximal flexion of the elbow will be there, so that the racket will be in a looping fashion behind the back. So the dominant arm will be extended, externally rotated and abducted, and there will be slight flexion of the elbow, so that the hand will be behind the back. Now the second phase is the cocking phase. Cocking phase begins with once the ball release and ends with the maximum external rotation of the dominant shoulder. This is a phase where the energy will be stored in the muscles, because the muscles, especially the anterior shoulder muscle, will be getting stretched, and this time the energy will be stored at the muscles. Now just after the ball release, for the ball release the non-dominant arm will be used for the ball release, and we lift the non-dominant arm, and at this stage once after the ball release the non-dominant arm slows its forward elevation and elbow extension while the racket loops behind the back. Now, at this stage, we can see a high degree of activity of the wrist extensors and triceps acting eccentrically to position the wrist, forearm and elbow, especially in the dominant arm. So, there we can see a high activity of wrist extensors and triceps, but this activity is an eccentric type of activity. So, its main function is positioning of the wrist, positioning of the forearm and elbow for the in the cocking phase. Now, the cocking phase, at the late cocking phase, it is the phase the shoulder goes into maximum external rotation. Late cocking phase is the phase where the shoulder goes into its maximum external rotation and abduction, and this is the phase where there is chance of maximum injuries. Shoulder, late cocking phase has potential injury to the shoulder. The shoulder is in a maximum external rotation, and the complete anterior capsule and anterior side and anterior and inferior glenohumeral ligament will be under constant tension to its physiological limits. So, there is chance of injury to the anterior structures and shoulder capsule also at this point. And the upward, along with that, there will be kinetic chain, and the upward driving force from the lower extremity forces the shoulder into a greater external rotation. So, because of all these, so there will be forcing from the lower extremities along with the maximum external rotation and abduction of the shoulder. There will be chance of compromise in the dynamic stabilizers, and later along with that there is chance of glenohumeral subluxation, impingement, overuse musculotendinous injury and muscular imbalance also. So, at this point the main function of the dynamic stabilizers, especially the muscle, are to keep the humerus in glenoid fossa. So, if there is any compromise in the dynamic stabilizers, especially the rotator cuff muscles, there is more chance of a subluxation, especially on the anterior side, and there is more chance of impingement, and there is chance of shoulder injuries, etc. Now, other areas at this stage, other areas of potential injury is the calf muscles, quadriceps, groin, intervertebral disc and pars interarticularis, because of hyperextension and rotation of the spine at this stage. Next stage is in the service motion is the acceleration phase. So, in the cocking phase, in the late cocking phase, shoulder goes into its maximum external rotation and it starts its internal rotation. So, acceleration phase means starting of the internal rotation until the tossed ball contact with the racket. So, acceleration phase means starting of the internal rotation till the ball contact with the racket. So, in the previous stage there was energy accumulation in the muscles, there was pre-stretching of the muscles. This is the phase where it represents the accumulation and release of all the forces and power generated by the kinetic chain. So, there will be kinetic chain, and along with that pre-stretching of the muscle, this accumulate the forces and release of all the forces will be there in this stage over the ball through the racket. Now, at this stage, the internal rotators, especially the internal rotation and adduction of the shoulder occurs. So, at this stage, the internal rotators and adductors of the shoulder act concentrically in a very powerful manner, because they have reached its maximum preload stretching, so that it will adduct, internally rotates its maximum force and does the motion. So, muscular injury at this phase is due to overload of the abdominal muscles, rotator cuff muscles, internal glenohumeral, internal rotators, adductors, elbow extensors and wrist flexors, because these are the motions occurring at this stage. So, these are the muscles commonly get injured. At the same time, there is a chance of a injury to the medial side of the elbow. So, it causes injury to the flexor and pronator muscles of the elbow, or flexor and pronator muscles at the forearm. Along with that, there is chance of injury to the ulnar collateral ligament of the elbow. Next stage is the follow through stage. It is the next stage in the service motion. Follow through stage means once the ball is in touch with the racket, until the completion of the stroke. So, mainly here the muscle action, predominantly the muscle action will be an eccentric type of action, because the deceleration motion of the rackets is going on. Now, along at this stage, at the follow through stage, there is horizontal adduction and internal rotation of the shoulder will be there, along with the pronation of the forearm. So, follow through stage means it is from ball contact until the completion of the stroke. So, the main predominant muscle action will be eccentric type of action, and there will be horizontal adduction and internal rotation of the shoulder along with the pronation of the forearm at this stage. Now, the posterior muscles will be affected at this stage. Posterior muscles will be acting at the stage, and these are the muscles usually, especially infraspinatus is the most commonly injured muscles, because the eccentric type of work is going on at this stage. Now, the function of the rotator cuff muscles are to keep the shoulder, to keep the humerus in the glenoid fossa. So, there will be a heavy work at the rotator cuff muscles, and there is more chance of injury of the rotator cuff muscles also at this stage, at the follow through stage. And along with that, the biceps, the main function of the biceps, it slows down the forearm pronation at this stage. So, and it assists in elbow extension. So, there will be heavy load at the biceps along with the rotator cuff muscles also. So, this biceps also may get injured at this stage. Now, we will go through the stages again of the service motion. That is, the first one is the wind up stage, next is cocking phase, next is acceleration, and the last stage is the follow through stage. Wind up phase stage means that is starting position until the ball release. Cocking phase means from ball release until the shoulder reaches its maximum external rotation. So, just after maximum external rotation, shoulder starts its internal rotation motion. Acceleration phase is the starting of this internal rotation motion until the ball contact with the racket. And the last stage is the follow through stage, and it means that once the ball contact with the racket until the completion of the stroke. Next type of stroke commonly seen in tennis is the forehand type of stroke. That is, it can be divided into three phases: a racket preparation phase, an acceleration phase, and a follow through phase. Racket preparation means from the starting position, from the initial position until the backward motion of the racket stops. At this point, there is flexion of the hip and knees will be there, and at the stage of racket preparation, initial stage, the shoulder, hip and trunk are in a parallel position with the net, and at this stage the trunk gets rotated, and then it will be the position of the shoulder and trunk will be in a perpendicular to the net. Second stage is the acceleration stage. Acceleration stage means that is, once it stops its backward motion, the forward racket motion starts. So, from forward racket motion until the ball contact, this phase is called acceleration phase. And the third phase is the follow through phase. Follow through phase means once the ball contact with the racket until the completion of the stroke. At this stage, there is elevation and adduction of the shoulder will be there, elbow flexion and forearm pronation will be there, and a recovery step is made with the rear leg, which is brought forward to a position level with the front foot. Next type of stroke is the backhand stroke. Backhand stroke again can be divided into three phases again: racket preparation, acceleration and follow through phase. So, the phases are similar like forehand stroke itself. Now, in case of acceleration phase, in case of backhand stroke, acceleration phase, there is more chance of more injuries at the acceleration phase. So, there are different studies have been conducted regarding the type of injuries and at different levels. So, either in the elite adult level or junior level or a senior level or veteran level, there are different types of epidemiological studies have been done. And studies are saying that in case of elite adult, male players are usually more injured than females. And upper extremity injuries are more common than lower extremity injuries in case of elite adults. And among the upper extremity injuries, shoulder injuries are the most common type of injuries. That is 17% of the all injuries. The shoulder injuries accounts that 17% of all type of injuries. Now next comes the back, elbow, hand, and ankle injuries. It comes around 11% of all injuries. Once we divide the different types of injuries, 65% of the injuries are overuse type of injuries. Strains are seen around 14% of injuries, and blisters and fracture. Blisters is around 5%, and fractures around 2% of the overall injuries are the fractures among the elite adult. So usually one thing we can notice that in elite adult, upper extremity injuries are more when compared to the lower extremity injuries. But at the same time, in case of elite junior level players, lower extremity injuries are more in case when compared to the upper extremity injuries. And another important thing is that most common injured site is the back, then thighs, hamstrings, then shoulder, then ankle. And we know the term, everybody will be knowing the term tennis elbow. Tennis elbow account the 6% of all injuries reported. And the most common type of injury in elite junior level is strains and sprains. Maybe strains and sprains of the back, maybe hamstrings, maybe ankles, etc. And usually once we go through the different types of ligamentous injuries, ligamentous sprain, the knee and ankle ligaments are the most commonly injured ligament among the elite junior level tennis players. So in elite junior tennis players, the lower extremity injury predominates upper extremity injuries. Now once we go through the specific tennis injuries, usually overuse injury are more commonly seen when compared to the acute injuries. Now usually this overuse injuries is in the upper extremities is due to the repetitive stroke techniques, and it includes usually rotator cuff tendinopathy, tennis elbow, wrist problems, etc. And when we go through the lower limb injuries, injuries to the knee, injuries to the feet, etc., usually associated with the terrain and the ground reaction forces and different gait cycles during the play. And injuries of the spine and abdominal region is usually associated with the twisting movements at the play, at the different stages of the play. There are lots of twisting movements during the different phases of the play. So the spinal and abdominal injuries are commonly due to the twisting movement associated transfer of impact forces. So once we go through the different injuries, specific tennis injuries, usually the common type of injuries are the overuse type of injuries. Now we will go through the region specific injuries. Usually first of all, wrist and hand. The causes of injuries, usually three types of causes are there once we go through the different injuries of the wrist and hand. The first one is a persistent controlled force, that causing, especially it causes tendinitis and overuse injuries. These are overuse type of injuries which is caused by persistent repetitive controlled force. Second cause of injury in the wrist and hand is which occurs due to a direct trauma, that is a hit by a racket or a fracture from a fall, etc., or even hit by the ball itself. So these are the injuries which occurs by direct trauma. And the third type of injuries is due to a sudden uncontrolled force, uncontrolled excessive force. So once we go through the different wrist and hand injuries, The causes of injuries are three types. The first one is a persistent controlled force which causes a overuse injuries, and the second one is a direct trauma, injuries caused by a direct trauma, for example fractures while due to a fall or hit by a racket, or from a sudden uncontrolled forces like strain. Now, the direct impact of the racket handle and the repetitive forceful whipping of the wrist in stroke cause a range of soft tissue injuries to the player's hand and the wrist. Non-dominant wrist pain is common in players using two-handed backhand shots. So, there will be a chance of non-dominant wrist pain. Then tendinitis of the wrist is common in players who place a lot of spin on their shot and improper technique. So, improper technique and the players who go for the lots of spin, there is chance of tendinitis, especially the extensor tendinitis will be there. Wrist extensor tendinitis will be there. Another common type of injury is the decurrence tenosynovitis. It is due to repeated ulnar deviation motion. And due to any improper technique, ulnar carpi ulnaris and brevis tendinitis is primarily it is due to overuse or technique flaws. Other common injuries seen in the wrist include fracture of the hook of the hamate, injury to the triangular fibrocartilage complex, ulnocarpal impingement, chondromalacia of the pisiform bone, ulnar nerve entrapment at Gwen's canal, median nerve entrapment at the carpal tunnel, and tricutrolunate ligament injuries. These are the commonly seen injuries in the wrist and hand region. Now, once we go through the forearm, injuries in the forearm, the common injury is the stress fracture of the ulna, of the non-dominant forearm, and distal and ulnar radial fractures of the dominant wrist also there. So, forearm injuries, especially fractures, are the most common type of injuries seen at the forearm level. And elbow level, once we go through the elbow level, the most important term is the tennis elbow itself. So, it is of the extensor carpi radialis brevis. So, it is also called lateral epicondylitis. The causes are usually an overuse. It is a type of overuse injury. It is an overuse injury of the extensor carpi radialis brevis muscle by repetitive micro trauma resulting in primary tendinosis. So, it may be due to predominant wrist extensor activity in all stroke of tennis. The risk factors for tennis elbow are, the first one is a faulty technique. Now, another risk factor is an increased playing time or concurrent repetitive activities. And other risk factors are racket, what type of racket the people are using. Either it is a wooden racket or aluminum racket or a graphite racket. That mainly depends upon the weight of the racket. That is, wooden and aluminum racket are heavy rackets, and there is more chance of injury once a person is using wooden or aluminum racket. So, graphite rackets, there is less chance of injury and it is tensile also. Next is the size of the racket. It should be an optimum size. So, the size, either it's an oversized racket, there is more chance of injuries. Weight of the racket we already discussed. A heavy racket cause injuries again. Grip size, there is a recommended grip size. We already discussed. It is the distance from the proximal palmar crease to the ring finger, to the edge of the ring finger. So, either it is too small or too large. So, again it's a risk factor for tennis elbow. Then depends upon what type of string and tension in the string also. Now, how we can prevent this tennis elbow? The first thing is that don't go for a heavy racket, and racket should be with less tension string has to be used. Then proper size, that is grip size should be proper, and proper stroke mechanics has to be done. That is, forehand stroke allows the player to hit the ball in front of the body. Forehand stroke should be in front of the body with the wrist and elbow extended. And if you are going for a backhand shot, the backhand stroke, that is, it should be supported by the opposite the other extremity, that is two-handed backhand stroke should be done, so that the shock can be reduced, the shock transmission will be reduced over the lateral epicondylae. So, preventive strategies is the proper equipment, proper technique and proper mechanics and proper the preventive strategies are the proper mechanics, proper technique and proper equipment. Now, what are the treatments we can give? We can go for ultrasound, we can go for phonophoresis, we can go for soft tissue mobilization, friction massage, stretching, strengthening exercise, etc. And the latest type of trend of treatment is shock wave therapy. Now, other common type of injuries seen among the tennis players are, the first one is another subacromial impingement syndrome. It is another type of overuse musculoskeletal injury seen at the shoulder. Another type of injury is the glenohumeral instability. So, these two injuries are seen on the shoulder and especially in the late cocking phase of the service motions. Another type of injury is the ulnar neuritis, inflammation of the ulnar nerve, that is mechanical stimuli or ulnar nerve in the carpal tunnel due to compression or traction from the valgus stress, particularly during the service motion. Next is the ankle sprain. It is one of the most common injuries seen among the tennis players, because the tennis players has to do a lot of lateral motion. So, mostly inversion in tennis due to the footwork required in stroke play and quick starts, stops and change in the direction of the stroke, it causes an ankle sprain. Now, we go through the different lower extremity injuries in tennis. The first one is the most common type of injury is the ankle sprain. So, the causes of ankle sprain, the mainly is the inversion type of injury. So, the tennis player has to move both sides. The sideways motion will be more when compared to any other sports in tennis. So, there is more chance of an injury to the ankle, or there is more chance of an ankle sprain among the tennis players. So, there is quick starts, there will be quick changes, quick stop, quick change in the direction. All these leads to an ankle sprain. Now, next common type of injury is the Achilles tendon rupture. It occurs when the player land on his toes with knee extended. So, high risk of movements in tennis include the first step forward after a serve and during the ground stroke, as forward and side lengths are made. Now, another common type of foot injury is the plantar fasciitis. So, usually it is also another type of overuse injury, especially seen in the players who are playing on hard court. The common cause is usually seen in those players also, those who do training on soft surfaces and switch the training into a hard court. So, there is more chance of plantar fasciitis. It is the inflammation of the plantar fascia at its origin. Next common type is another overuse injury. It is the shin splint or periosteitis. And another common type of injury is the tennis toe. Tennis toe means bleeding under the nails of the toe caused by toes being jammed against the shoebox. And corns and calluses are also seen. These are the most common type of foot injuries seen. So, foot injuries include plantar fasciitis, shin splint, tennis toe, corns and calluses. Another commonly seen commonly seen injury is the calf injury, that is tennis leg. It is nothing but strain of the gastrocnemius muscle at the calf. So, there will be a sharp burning type of pain at the junction of between the upper third and lower two-third, upper one-third and lower two-third of the muscle. There will be a sharp pain. It is due to the strain of the gastrocnemius muscle. The cause is a sudden dorsiflexion of the leg, where the knee is previously extended and angle is plantar flux, and it is usually seen among the tennis players, and most commonly seen this type of injury most commonly seen in younger male tennis players. In this session of the class, we have gone through different types of motions and we analyzed the different types of motion. We will go through the different types of motion again. The first one is the serve motion. Serve motion, we divided in the serve motion into 4 categories. That is the wind up phase, that is wind up phase from starting position until the ball release. Next is the cocking phase from ball release until maximum external rotation of the shoulder. Then acceleration phase, that is internal rotation of the shoulder until the ball contact with the racket, and follow through phase, that is ball contact until the completion of the stroke. Then we discussed about the forehand stroke. Forehand stroke we divided into 3 phases, that is racket preparation phase, acceleration phase, and follow through phase. Then we discussed about the backhand stroke. Backhand stroke, again it can be classified into 3. That is racket preparation phase, acceleration phase, and follow through phase. Then we discussed about the different commonly seen injuries among the tennis players. That is, among the elite adult, male players are more injured. But at the elite junior level, lower extremity injuries are commonly seen. And overuse type of injuries are commonly seen when once we go through the different types of injuries. We have gone through the regional specific injuries of the at different regions like wrist, forearm, elbow injuries. We discussed about the lateral epicondylitis or the tennis elbow also. We have gone through different strategies to avoid this type of injuries. Welcome back. In this session, we will be discussing about the exercises of the lower limb. Lower limb, once we go through the different, before going through the different lower limb exercises, we should have some brief idea regarding which are the muscles which work on the lower limb. Especially in this session, we will be discussing about the different muscles and different exercises, especially around 3 joints. The first one is hip joint muscles, including hip flexors, extensors, abductors and adductors of the hip joint. Then we will be discussing about the knee joint, that is the muscles of the knee joint, especially the flexors and extensors of the knee joint, that is hamstrings and quadriceps muscle group. Then in the ankle joint, especially the plantar flexors and dorsiflexors of the ankle joint. Now we will start with the hip joint now. The first muscle, one important muscle on a hip extensor is the gluteus maximus muscle. So we will go through the anatomy of the gluteus maximus muscle first. Next. Gluteus maximus is the posterior muscle of the hip joint. It is the largest and most superficial muscles of the glute among the all glute muscles. It makes up a large portion of the shape and appearance of the buttock. Next. Now the gluteal muscle, it originates from the gluteal surface of the ilium, lumbar fascia, sacrum and sacrotuberous ligament. And it inserted to the gluteal tuberosity of the femur and IT band or iliotibial tract. Next. Its main action is extension of the hip joint. Along with the extension, it does the external rotation of the hip. It supports the extended knee through the IT band, and it is one of the anti-gravity, or we can say it is the chief anti-gravity muscles in sitting. The nerve supply is from the inferior gluteal nerve. Now in this session we will be showing different exercises which improve the strength of the gluteus muscle, especially the gluteus maximus muscle. So along with the gluteus maximus muscle, there may be some synergetic muscle, which synergetic muscle or synergetic action of some muscles which also get strengthened. And along with this exercise, some muscles may get stretched also. So these are exercises targeting the gluteus maximus. But along with this gluteus maximus, we will get strengthening of the other muscles and get stretching of the other muscles also. So now we'll start with the first exercise, that lunge. Subject should be in standing position. Then we are asking the subject to lunge forward with the first leg. Lower the body by flexing the knee and hip. Lowering the body by flexing the hip and knee of the front leg until the knee of the rear leg is almost in contact with the floor. Now we are asking the subject to return to the original standing position by forcefully extending the hip and knee of the forward leg. Repeat by alternating lunge with opposite leg. So the subject should be standing position. We are asking the subject to lunge forward with the first leg and then return to its original position by forcefully extending the hip and knee and repeat the same lunge with the opposite leg. So we have to keep the entire body straight during the lunge and flex, and in this case we have to forcefully extend the hip and knee, and a strong long lunge emphasizes the gluteus maximus. Short lunge, if we are doing a short lunge, the emphasis will be on the quadriceps muscle. The next exercise we are performing is the dumbbell lunge. It is a modified form of lunge that is keeping the dumbbell on his hand, so that more resistance, more weight will be there for the gluteus maximus muscles. The subject should be in standing position with the dumbbells grasped on his hand on both sides. We are asking the subject to lunge forward with the first leg and land on the heel, then forefoot. We are asking the subject to lower the body by flexing the knee and hip until the front of the leg and knee of the rear leg is almost contact with the floor. Then we are asking him to return to his original position by forcefully extending his hip and knee and repeat with the alternating leg. We repeat with the alternating lunge with the opposite leg. So for the lunge, the subject should be in standing position first with the dumbbells grasped on his sides, then lunge forward with the first leg, then land on the heel, then forefoot. Then we are asking him to lower the body by flexing the hip and knee of the front leg until the knee of the rear leg is almost touching with the floor. Then we are asking him to extend his knee and hip very forcefully and repeat with the alternating lunge with the opposite leg. Next type of lunge, or next type of strengthening exercise is the barbell lunge. Here, it's a modified type of lunge. Here we are keeping the barbell at the upper chest height, that is on the back of the shoulder at the chest height. We are keeping a barbell and doing the lunge. Again, we are giving a force so that more strengthening can be done over the gluteus maximus muscle. So the exercise we are going to perform is the barbell lunge. So we are asking the subject to keep the barbell on his back of the shoulder, that is at the upper chest height, and grasp the barbell with his upper arm. Grasp the barbell to the sides. Then we are asking the subject to lunge forward with the first leg. Then lower the body and until the knees of the rear leg is almost in contact with the floor. Return to the original standing position by forcefully extending his knees and hip. Then repeat the alternate lunge with his opposite leg. This type of exercise is called barbell lunge. The exercise we are going to perform here now is the barbell rear lunge. It is again the modified form of a lunge. Next type of lunge we are going to perform. The type of lunge we are going to perform is the barbell rear lunge. The subject should be standing position and he should keep the barbell on the back at the shoulder, at the back of the shoulders, at the up chest level or the upper chest level. Now we are asking the subject to step back with one leg while bending the supporting leg. Plant the forefoot far back on the floor. Now we are asking him to lower the body by flexing the knee and hip until the knee of the rear leg is almost in contact with the floor. Now he will be coming back to the standing position with forceful extension of the hip and knee, and repeat the movement of the opposite leg with the alternating leg. So keeping the torso or keeping the body straight is very important. Very important in this type of lunge, because and the flexible hip flexors and flexible hip flexors and a strong hip extensors are needed for this type of lunge. A long lunge emphasizes the gluteus maximus and short lunge emphasizes the quadriceps. Next exercise we are going to perform is the lying hip extension. So in order to perform the lying hip extension, the subject should lie on the floor or mat. We are asking the subject to keep the one leg straight and the other leg bent over the mat. Now the position of the arms. Place the arms down on the mat to the each sides of the hip. Now we are asking the subject to raise the body by extending the hip of the bent leg, keeping the extended leg and hip straight. Then after a few seconds, the subject can return to the original position by lowering the body with extended leg and hip straight. Repeat this exercise 3-4 times and continue with the opposite side also. So this exercise is called lying hip extension. So again I am explaining, the subject should be lie on the floor or mat. One leg should be straight, the other leg should be flexed. One leg should be straight and other leg should be flexed. And raise the body by extending the hip of the bent leg, keeping the extended leg and hip straight, and we are asking the subject to return to the original position by lowering the body with extended leg and hip. Repeat and continue with the opposite side. The next exercise we are going to perform is the reverse. Reverse hyperextension. For this exercise, we are asking the subject, the upper side and the waist will be supported. That is, the subject should be lying with the upper side of the body and up to the waist, and the waist on a bench, and grasp the handles. Now, the lower side will be out from the bench. Now, feet should be above the floor with the legs straight. Now, we are asking the subject to raise the lower side by extending the hip as much as possible. And we are asking the subject to try to make his legs almost straight with almost in the same line of the body. Then after some time, after few seconds, we are asking the subject to lower his legs and goes to the original position. And repeat the exercise 3-4 sets. Again I am explaining the reverse hyperextension. That is, we are asking the subject to lie on a bench and grasp the handle. But once we are lying, only the upper side will be supported, lower side would not be supported. Up to the waist it will be supported. Now we are asking the subject to raise the lower side up or extending the hip and keep the body straight, or lifting the lower side as much as possible. Now after a few seconds, relax and goes to the previous position. So the exercise we performed here, in this exercise, that we are keeping the knees bent, or we are flexing. In this exercise, the exercise we have performed, we are keeping the knees straight. Now, if we are keeping the knees bent, so the exercise become much easier. And if we want to make the exercise more resistance or more harder, we can put an additional weight on the lower side. We can put either a sandbag or an additional weight on the lower side of the foot, lower side of the leg or in the foot, and we can make the exercise more harder. Next exercise we are going to perform is the weighted reverse hyperextension. So it is almost similar like the reverse hyperextension. Here we are making the exercise more harder by keeping a weight on the lower side of the body. So we can place a sandbag or medicine ball either between the ankles or with the feet. Now we are asking the subject to lie on a bench. Lie on a bench, but only the upper side will be supported by the bench. Upper side and waist will be supported by the bench. Now, we are asking him to raise the lower side along with the weight. That is, raise the weight along with the lower limb as high as possible until the legs are straight or in a straight line with the upper side of the body. Now, lower the leg. We are asking him to lower the leg and goes back to its initial position or original position. And repeat the exercise 2 or 3 times and 2 or 3 sets also. The next type of strengthening exercise we are going to perform is the barbell squat. The subject should be in standing position and the barbell should be on the back of the shoulder. Grasp the barbell with his fingers or hand and keep the barbell close to the shoulders and position the elbow back. Now we are asking the subject to bend his knee and hip and move down. That is, bending the knee forward and flexing the hip also. And descend, and we are asking him to descend until the thighs are just parallel to the floor. Now we are asking him to forcefully extend the hip and knees until the legs are straight. Again return and repeat the exercise. Again I am explaining the same exercise again. That is barbell squat. The position should be, the subject should be in standing position with keeping the barbell below the behind the shoulders or back of the shoulders and grasping the barbell with the hand. Grasping the barbell to the sides with the close to the shoulder and position the elbow back. We are asking the subject to bend his hip and knee until the thighs are just parallel to the floor. Extend the hip and knee forcefully until the legs are straight. And repeat the same exercise 3-4 times. The next exercise we are going to perform here is the single leg split squat. The exercise we are going to perform is the single leg split squat. The subject should be facing away from the bench. We are asking the subject to extend his one leg back. Place the top of the foot over a bench, on a bench. I'll explain it again. We are asking the subject to stand facing away from the bench. We are asking him to extend the leg back and place the top of the foot on the bench. Now we are asking him to squat down by flexing the hip and knee until the knee of the rear leg is almost in contact with the floor. We are asking him to go back to the original position by flexing the hip and knee, extending the hip and knee again, and of the forward leg. Repeat it and continue with the opposite leg. The next exercise we are going to perform here is the single leg squat. We are asking the subject to stand and keeping the arms extended towards the front side. That is, with the flexion of the shoulders, he is keeping the arms towards the front side. Balance on one leg with the opposite leg extended, that is with the flexion with the opposite leg, that is with the by the flexion of the hip. That is, it is straight. We are keeping the leg forward with the by the flexion of the hip. We are asking the subject to squat down. We are asking the subject to squat down with flexion of the hip and knee, and we are asking him to return to its normal position. The exercise we performed right now was the single leg squat. Now, single leg squat can be made bit easier by getting some assistance. The name of the exercise is called self-assisted single leg squat. Here we are doing we are standing in front of with the help of a horizontal bar, and we are getting the support of a horizontal bar, that is through the hand. So it is called self-assisted single leg squat. Now the exercise we are going to perform now is the single leg stiff leg deadlift. The subject should be in standing position with the feet together and hands just in front of the thighs. Now lift the leg slightly, so that the foot will be lift one leg slightly, so that the foot will be just off the floor. Now we are asking him to lower the torso forward and downward while raising the lifted leg back behind. Keep the back straight and knees of the supporting leg slightly bent. Keep the hip and knee of the lifted leg extended throughout the movement. Once the stretch is felt, or hands contact to the floor, return to the original position by raising the torso, raising the body while lowering the lifted leg. Straighten the knees of the supporting leg as the torso become up straight. Repeat the exercise. Okay. Repeat. The target muscle is the gluteus maximus muscle of the supporting leg. But along with the gluteus maximus muscle, some more muscles also doing the synergetic action. The muscles are hamstring and adductor magnus. So all these three muscles, that is including the gluteus maximus, hamstring and adductor magnus, perform this exercise. The next exercise we are going to perform here is the barbell single leg stiff leg deadlift. Here it is almost similar like single leg deadlift, but here we are increasing the resistance by using a barbell. Throughout the lift, keep the arms and back straight. Do not lower the weight beyond the mild stretch throughout the hamstrings. Then full range of motion will vary from person to person. At the top of the movement, lifted foot can make contact with the floor to maintain the balance between the repetition. The next exercise we are going to perform here is the dumbbell single leg stiff leg deadlift. This is also a modified form of stiff leg deadlift. But here we are using the dumbbell, and here instead of barbell, and here we are using the dumbbell in order to increase the weight, in order to increase the resistance. The exercise we are performing here is now the dumbbell single leg stiff leg deadlift. The subject should be in standing position. Hold the dumbbell in each hand. Position the dumbbell down in front of the upper thighs. Hold the dumbbell on each hand. Position the dumbbell down in front of upper thighs with the arms straight. That is, elbow should be straight. Stand with the feet together. Then the one leg has to be lifted slightly so that the feet will be just off the floor. Now lower the dumbbell to the floor while raising the lifted leg back behind. Keep the back straight and knee of the supporting leg slightly bent. Keep the hip and knee of the lifted leg extended throughout the movement. Once the stretch is felt, or if the dumbbell comes in touch with the ground, he can go back to the previous position by lowering the lifted leg. Straighten the knees of the supporting leg as torso become upright. and repeat the exercise. You can repeat the exercise with the opposite leg also.